Hello and welcome to the Hormone Zoomer Boot Camp. This is session 3 out of 5. Today's topic is methylation and estrogen metabolism, what detox pathways reveal about disease risk. My name is Adair Anderson. I'm the product marketing educator here at Vibrant and want to go over some quick housekeeping items before we get started. All attendees are in listen-only mode, so if you have questions during this presentation, please submit them as a comment. We will have time at the end for Q&A. This bootcamp session is being recorded, and you will get a copy of the recording and slides after the session ends. And also, you can access the slide deck right now in the caption below the video. And now I'm pleased to introduce you to Dr. Sara Zoll. Dr. Sara Gottfried Zoll is a board-certified physician who graduated from both Harvard and MIT. She practices evidence-based integrative precision and functional medicine. She is clinical assistant professor in the Department of Integrative Medicine and Nutritional Sciences at Thomas Jefferson University and the director of precision medicine at the Marcus Institute of Integrative Health. Her 3 New York Times best-selling books include The Hormone Cure, The Hormone Reset Diet, and Younger. Take it away, Dr. Zoll.
Thank you so much, Adair. Good to be with you all today. I am thrilled that we get to talk about methylation and estrogen metabolism. I feel like this is a critical part of precision and functional and integrative medicine. So some of this might be a review for many of you. It may be new information, and we want to make sure that we also answer your questions. So we'll take some time in the middle of this webinar and then also at the end to get to your questions. Feel free to start filling up our Q&A with that and think about it as we go along. So I don't have any disclosures. We're going to be focusing today on estrogen metabolism and methylation pathways, how to manage them, how to use testing to map metabolite patterns, especially how that can indicate disease risk. We're mostly going to be talking about women today. I take care of both men and women. In fact, I've got a executive that I'm taking care of as soon as we finish the webinar, so I'll be running off to do that. And then we'll also talk about genomics, which I think is a critical part of understanding the map of estrogen metabolism as well as methylation. So I want to start with a case because I think cases really make metabolism come alive. This is a 42-year-old woman. In fact, I had a patient this morning who's very similar to this case. 42-year-old woman with a family history of ER-positive breast cancer. She's reporting poor sleep, anxiety. Her periods are getting a little closer together, which can indicate that she's in the first initial stages of perimenopause. Her estrogen metabolism testing showed elevated 4-hydroxyestrone and also impaired methylation, which is something we see in so many of our patients. So this woman doesn't have a diagnosis, but her risk, especially with impaired methylation and the 4-hydroxyestrone pathway, is biochemical. It's not just clinical. And in precision medicine, we want to intervene before something becomes clinically manifest. So that's what we're really going to focus on today in the content. The disease, the pre-disease can start decades before diagnosis if you know where to look. In functional medicine, if I go back to 30 years ago when I first started listening to Jeff Bland and the beginnings of functional medicine, what we think about is not just what your hormone levels are, estrogen, progesterone, testosterone, cortisol, DHEA, pregnenolone. We also think about what's the control system that regulates these key hormones. And so the control system is what we want to keep in mind. That's really what separates conventional medicine from the approach that we're talking about today, precision medicine, functional medicine, integrative medicine. And that control system is basically from the top down. So hypothalamus, pituitary, adrenal axis, but we want to expand that axis a little broader to include the thyroid, the gonads, so ovaries in women, testes in men, the place where we've got the most mitochondria, and you start to see mitochondrial aging really early on. It also includes the gut. So many of you know this already, that when it comes to estrogen metabolism, the gut is involved. And if you've got more of the bacteria, the three type of bacteria that produce beta glucuronidase, that can lead to recirculation of estrogens. So the gut is really critical, as well as the genome. So these are all the factors that control and regulate your hormones, especially sex hormones. It's not an exhaustive list, but it's a good one to start with in terms of a framework. I know it's hard to read this slide, but what I want to make really clear here at the beginning is that when we're talking about estrogen metabolism, the way that we think of the steroid hormone cascade is that we start with cholesterol. And this is a critical point because, I've had my cholesterol levels change over my lifetime. And when I was in medical school at Harvard, when I was taking anatomy, I was so kind of freaked out by uh, dissecting muscles and dissecting flesh that I became vegan. And when I became vegan, my estradiol levels plummeted. They went from a pretty healthy level down to pretty close to zero. And that led to a number of symptoms. I had mood issues, I had a number of other issues, but it speaks to something that we see a lot in our patients, which is cholesterol is converted into sex steroids. And it starts first with the conversion of cholesterol to pregnenolone. Pregnenolone is considered the mother sex hormone. And we want our patients to have a level of pregnenolone at about 100. And then in terms of the sex steroid cascade, the way I think of it is that you can either turn right and go to progesterone and then all the progesterone metabolites. This then can be converted to 17 hydroxy progesterone, which goes on to produce testosterone and also the estrogens. So the way I think of it is that you have to make sure that you've got the Goldilocks position with a number of these sex steroids. So you don't want to just look at metabolites. You don't want to just look at serum levels of DHEA, testosterone, cortisol. You want to look at the whole picture, including what's going on with cholesterol, what's going on with pregnenolone. How are these pathways being activated? How are the enzymes working? And there's, of course, genomic control for many of these pathways, as we'll get into today. So here's kind of the basic version of estrogen metabolism. There are all these CYP pathways that lead to what some people think of as the good, the bad, and the ugly estrogen pathways. Those are the good 2-hydroxy, bad 4-hydroxy, and then the so-called ugly pathway. I don't like these terms, but it's what's generally used, 16-hydroxy. And then once sex steroids go through these pathways, they then get methylated via the COMT gene. So more on that in a moment, but I just want to highlight some of these pathways. The 2-hydroxy pathway, the enzyme that's involved is CYP1A1, 1A1. This is the so-called protective route. I like these terms better than good, bad, and ugly. So the safe route, the protective route to the 2-hydroxy estrogens. There's the CYP1B1, which is the fire starter that goes to the 4-hydroxy pathway. And then CYP3A4, which is kind of the wild card, and that goes to the 16-hydroxy pathway. And then COMT is the primary methylator, and that's the firefighter. It methylates and neutralizes 2 and 4-hydroxy. So the key is that you don't want to focus just on estrogen levels. You want to think about the pathway and how that defines risk. And so I'm curious how many of you are checking hormone levels. I assume because you showed up for this boot camp and this particular webinar, all 1,200 of you, welcome, that you're already checking some of these pathways. But if not, I just want to make sure everyone feels included here. If you're not, the idea here is that if you're not checking the levels of hormones with a test like Hormone Zoomer or one of the other tests that looks at estrogen metabolism, if you're not looking at metabolism, you're really flying blind. And you have no idea what sort of risk someone has in terms of producing more of um, the safe type of protective estrogens versus the less safe, the more risky, potentially dangerous ways. So you want to be thinking about the pathways and how they define risk. So the pathways are shown here. We've got estrone converting back and forth to estradiol, and how this can also convert to estriol. We'll talk a little bit about these different types of estrogens. Estrogen becomes more dominant after menopause. Estradiol or E2 is the type of estrogen. E1 is estrone. E2 is the type of estrogen that women make primarily during their reproductive years. It's the most potent estrogen that we make as women. And then estriol E3 is the type of estrogen that you make primarily in pregnancy. And so all of these have different receptor affinity. We'll talk a little bit about what regulates the activity of estrogens in the body. But these pathways are shown here again. So first is this protective pathway shown in yellow, where we're converting estrogens to the 2-hydroxy pathway. And then shown in red is the 4-hydroxy estrone pathway via CYP1B1. And then what's shown here at the top is the 16-hydroxy pathway with CYP3A4 as the enzyme. So these are the 3 different enzymes that we really want to focus on, as well as the role of COMT, which is indicated here in terms of methylation, as well as the role of glutathione, which helps to detoxify the 4-hydroxy pathway. And if you're a little lost talking about the biochemistry, hang on with us because we're going to keep layering in and simplifying this process. So I want to start first with the 16-hydroxy pathway. This is the one that is the enzyme involved is CYP3A4, which is also the name of the SNP that's involved in converting the estrogens to the 16 alpha hydroxy estrone. So this is considered more biologically active in terms of the type of metabolite. It binds relatively tightly to estrogen receptors, and it can promote tissue growth. So I always think about this in terms of breast cancer risk. And I also think of it in terms of other clinical findings like endometriosis, fibroids, as we'll get into in a moment. So unlike the 2-hydroxy pathway, the protective pathway, the safe pathway, 16-hydroxy isn't easily neutralized by the COMT SNP, by the COMT gene. So the idea with the 16-hydroxy pathway is that it's strongly estrogenic, it's long-lasting, and it's potentially risky. So what we want to do to be able to manage this is to measure it with laboratory testing, and then implement a precision medicine, functional medicine, lifestyle medicine approach to try to optimize this pathway, depending on what's going on with the genome. The 2-hydroxy pathway, the so-called safe route, is where you have enhanced metabolism through the 2-hydroxylation pathway, and it's associated with a reduced risk of breast cancer. So women who make plenty of 2-hydroxy estrone, who have an active 2-hydroxy pathway, we know that they have higher ratios of 2 hydroxylation metabolites, they have a lower risk of breast cancer. That's why it's considered the protective pathway. And then the 4-hydroxy pathway, in many ways, is the most interesting one to me because this is the pathway that's associated with quinone formation. So when patients have SNPs that are associated with higher levels of 4-hydroxy estrogens, they make more DNA adducts. It can cause mutations in the body. It can lead to a greater risk of breast cancer. So we think that for people who are making more of the 4-hydroxy pathway and then they have poor methylation, they can get this carcinogenic backlog. And the data shows that for those who have less extensive methylation of the 4-hydroxy pathway, those catechols can be genotoxic and associated with a greater risk of breast cancer. And you've got some of the latest citations that are listed here on the slide. You're going to get access to these slides if you don't already have them. And then in terms of methylation, there's so many different factors that we want to consider. You know, when I first started looking at estrogen metabolism, mostly we paid attention to COMT and to MTHFR. So COMT to look at estrogen catechol detox, MTHFR to look at methylfolate production. But there's more SNPs that are involved. You know, at last count, the ones that have the best data, there's a total of about 15 different SNPs that are involved in the methylation pathway. And you might be familiar with this if you're doing metabolism testing, such as with the Hormone Zoomer. So we want to pay attention to SNPs and how those govern methylation mechanics. So there's the COMT Val 158 MET SNP. There's the MTHFR 6 C677T, as well as many others in the methylation pathway. So you can then influence this pathway with methylators, with methylated B12, methylated folate, which is B9, magnesium, choline. The idea here is that methylation is a biochemical firewall. It's a way of protecting our patients, and it's underpowered in many of our patients. So that then speaks to the why. Why are we talking about Hormone Zoomer? Why are we talking about estrogen metabolism and methylation? The why is we want to identify those people who are underpowered, who have a biochemical firewall that's not working properly. And so doing more comprehensive testing than just static serum testing, but adding on to that things like the Hormone Zoomer, that allows us to see who's underpowered and how we can work around that genomic risk and the biochemical risk. So what happens with a lot of our patients is that they have a detoxification bottleneck. And the way that you can think about this is what typically happens with the different phases of detoxification in the liver is that the first phase, which is mostly hydroxylation, speeds up. So it gets really fast. And then the second phase, which is methylation, can slow down. And that leads to a problem where phase 1 is fast, phase 2 is slow, and you get these toxic intermediate metabolites that are stuck in limbo. I think of it like bad karma that just keeps recirculating. We don't want that. So there's a number of things that can influence this problem with the detoxification bottleneck. It's something that I see in probably 80% of my patients. My patients are really enriched in this quality because, you know, maybe they went to someone in perimenopause or menopause and they got started on hormone therapy and they'll feel better for a week or 2 or 6 weeks and then they backslide. And those are the patients I'm always sort of perking up my ears, listening for a history like that, because often the issue is they have a detoxification bottleneck. So that's a quick clinical pearl. And there's a lot of things that you can do to influence this bottleneck, including testing genetics, looking at some of the genomic pathways. You can modulate inflammation with lifestyle medicine. You can address nutritional gaps. Maybe someone is one of the 70 to 80% of Americans who do not have sufficient magnesium. And so they need additional magnesium. They need more methylators to support them. And the idea here is that it's kind of like a highway on ramp that is not working properly. And so we want to be able to let the flow on the highway or the freeway work the way it's intended to work without a bottleneck. So when you're looking at different tests, different hormone tests, and I feel like I've used all of them over the years, here's what you want to look for. You want to be able to test the hormone levels, but then you also want to be able to test the metabolites, especially the 2-hydroxy, the 4-hydroxy, the 16-hydroxy, and then the methylated estrogens. You want to have some insight into these different phases of detoxification, phase 1 and phase 2. So, I have another example here of someone who's got low 2-methoxyestrone and high 4-hydroxy estradiol. This is a clinical pattern that you want to be able to recognize because it's an early warning system. As we talked about, this patient with this biochemical bottleneck may not have any symptoms. And when this exists over the years, over the decades, it can lead to a greater risk of breast cancer, also a greater risk of endometrial cancer. And those are things that are preventable. I remember when I first started doing this work and I became friends with Philomena Trindade. And one of the things that she said in her teaching at the Institute for Functional Medicine and also at the American Academy of Anti-Aging Medicine, place where I also teach, she said that if you're not checking metabolites and you've got a patient on hormone therapy, that is not good medicine. You really need to be checking these metabolites if you're prescribing hormones. And I agree with that. So I don't know that the evidence supports it being standard of care. Currently, it doesn't. But I would say anything we can do to support our patients to help them with their metabolism so that we can avoid this detoxification bottleneck, we should be ordering these tests. If the patient can afford it, we should order it. So another key point is that this is not just breast cancer risk because estrogen detoxification impacts the whole body. It impacts the brain. In some ways, I feel like over the years, I was taught to really focus on hormone therapy. And this is going back 35 years now. Got some gray hairs. I was taught to give hormone therapy mostly for the cardiovascular benefit. And that's held up over time. So we think that women, especially within 10 years of menopause, have a net benefit in terms of cardiovascular disease compared to women over the age of 60 or more than 10 years from menopause. So I was taught to give hormone therapy. This was before the Women's Health Initiative was published. I was taught to give it for the cardiovascular benefit because that's the number one killer, right? And WHI kind of muddied the waters. I think we can all probably agree to that there's been misinterpretation, reinterpretation. I believe it was the wrong study in the wrong women, at the wrong time in their lives. And really, we need to be giving hormone therapy much earlier than the mean age of 63 that we had in the Women's Health Initiative. We need to be using bioidentical hormones, and we need to be checking metabolites. But what shifted over the years that I've been prescribing hormone therapy is that I'm mostly focused on brain health. So I think that is the key reason to give hormone therapy. And what we know with the brain is that the catechol estrogens can affect a number of different outcomes for women: mood, cognition, neurotransmitter balance. And the mechanism is that the estrogen metabolites, like the 2-hydroxy and the 4-hydroxy forms, can interact with dopamine as well as other catecholamine pathways. So that can influence focus, memory, and mood regulation. It's one of the reasons why, like with the patient I saw this morning, she's 49 years young, and she's noticing that her tendency toward attention deficit is getting worse. And we often see that related to lower estrogen levels as well as metabolites that are accumulating. We've talked about the effect on the breasts. The key issue here is that certain estrogen metabolites, like the 4-hydroxy, can form quinone adducts, and those can damage DNA. So this again relates to the reactive intermediates that we've talked about that can initiate mutations that elevate breast cancer risk and also endometrial cancer risk. So estrogen detox is also involved in the liver as well as the gut. A couple of key issues here. The estrogen metabolism relies on methylation and conjugation pathways, and that can increase oxidative stress when it's overloaded. Oxidative stress is one of those things that many of us talk about, and most patients have no idea what we're talking about. I tend to talk about it like, okay, you take a bite of an apple, you leave the apple sitting there on the table for an hour, you come back and it's brown. That's what oxidative stress is like. It's kind of like rust in the body. And so if you've got more of these intermediate pathways, it can increase the oxidative stress. And we know for women who go through perimenopause, menopause, they develop more oxidative stress, especially if you've got genomic risk of that. And then in the gut, we talked already about these 3 different bacteria. Maybe there's more that we know about by now that are associated with more beta glucuronidase activity, an enzyme that these bacteria produce. And that can then kind of uncouple detoxified estrogens. It sort of undoes the benefit that you get. And it can lead to this enterohepatic recirculation of estrogens, causing estrogen dominance, potentially leading to a greater risk of breast cancer, endometrial cancer, and in men, potentially prostate cancer. The other piece that we want to be thinking about is the endocrine system does not exist in isolation. The way I think of it is that it's part of the PINE network, the psycho-immuno-neuroendocrine network. And this network is under siege in some women. It can be under siege in women who've got autoimmunity. It can be under siege in women who've got endometriosis, which I think of as an autoimmune condition. It can be under siege in women with polycystic ovary syndrome. And then women age and they get to perimenopause and menopause, and the PINE network can become even more dysregulated. So the point here is that when you have dysregulated estrogen metabolites, it can alter these other systems, your immune signaling, your hypothalamic, pituitary, adrenal, thyroid, gonadal, gut, genome axis. It can also increase inflammation. So these key SNPs that we want to be thinking about in terms of detoxification and metabolism are the COMT. If you have low activity, that can lead to a stall in methylation, MTHFR, as well as other SNPs in the methylation pathway, CYP1B1. If you've got too much of it, it leads to 4-hydroxy dominance. And then there's also the glutathione SNPs like GST and UGT. And so I tend to do genomic testing in all of my patients. You don't have to do it that way. I'm the director of precision medicine at Jefferson, as Adair mentioned. So I see patients who want to get their genome tested, and you can do that now pretty thoroughly for about $300. But not everyone needs it. What you could do is you could start with a test looking at methylation, mapping methylation and estrogen metabolism, and from there, determine whether genomic testing is worthwhile. But the key here is that you don't want to guess. You want to test, and then you want to personalize the treatment because there is no one size fits all when it comes to hormone balancing. I think we can all agree to. So let's talk about some of these SNPs. So I'll start first with COMT. This is a really common SNP. It's RS4680. I check it in every patient. What we know is that the MET allele, also the A allele, is we see it in approximately 25 to 50% of individuals. There's some variability across different populations, but it leads to a 3 to 4x reduction in enzyme activity for the MET allele. So that's really recent data, and it leads to overall a problem with methylation. So when we think about estrogen metabolism, we think about that initial phase with CYP1A1 and 1B1 and 3A4. And then we think of that next phase, which is the methylation. You want to clear up the methylation first. So I always make sure my patients are methylating first. That's in their clinical parole. It's one of the reasons why I'm starting with COMT here. Then there's the MTHFR. Here's some of the SNPs that are involved, the 677T, A1298C. And these are really common. So the homozygous version is present in 10 to 15% of Caucasians. The compound heterozygous state is also very common. I think the last number I saw was 53% of our patients. And this can lead to an up to 70% reduction in enzyme activity. So it impairs methylfolate production and SAM synthesis. We know that if you've got one copy of the T allele, that leads to a 30 to 70% reduction in enzyme activity. So it's pretty substantial. CYP1B1, you've got the SNP listed here. This is the variant. The SNP is present in 30 to 50%, depending on your ancestry. And this leads to a greater risk of 4-hydroxylation of estradiol, and that can be pro-carcinogenic and DNA damage. So you've got some of the key citations listed here if you want more information. So these are some of the labs that I run on my patients. I like to look at serum estradiol levels. I do that on all of my patients, male and female. Estradiol is really important for men. Progesterone is really important for men. So I do serum levels on all of my patients. I also look at homocysteine because that is a functional test looking at methylation. I look at B12, folate, and also follicle stimulating hormone. We're not talking about it today, so I'll just give you another quick parole on this. You may be familiar with Lisa Mosconi, who is the head of the Alzheimer's Prevention Clinic at Cornell. She's also the head of the Women's Brain Initiative. And her work is showing that for our patients who are menopausal, who have higher FSH levels, that's associated with a greater risk of Alzheimer's disease. So I'm always tracking FSH in my patients. That woman I saw this morning, the 49-year-old, I haven't done her metabolites yet. That's coming next. But she had an FSH of about 25, and that's right on the borderline. Even though she's cycling regularly, that's right on the borderline between perimenopause and menopause. So in the urine, I run estrogen metabolism mapping. I'm looking at metabolism of other hormones as well, including cortisol and the androgens and progesterone. But our talk today is mostly on estrogen, so I won't speak to those. And then you've got the genomics that we've already listed. I often run a comprehensive stool test in my patients looking for beta glucuronidase and whether they've got that recirculation, like that karma of their estrogens. Sometimes I do a serum anti-Mullerian hormone as a way of predicting when menopause is going to occur. I look at serum testosterone levels, thyroid function, MMA to look at B12 levels. Sometimes I look at organic acids or methylation intermediates. And then I tend to look as well at genomics. So a couple of clinical takeaways, I think this is maybe one of the most important slides if you're looking at metabolites in your patients. We want to think about, for our patients who've got the COMT SNP, magnesium can be really helpful. So can methyl B12 and CME. For patients who've got a high 4-hydroxy pathway, think about dim diendyl methane, which is derived from cruciferous vegetables, uh, indole 3 carbinol in green tea extract. For people who have a low protective pathway, the 2-methoxyestrone pathway, you want to think about methyl donors, beets, B12, B2, folate, liver support. For people who've got the MTHFR variant, I feel like you probably know these well. Once again, methylated folate, avoid synthetic folic acid. And then for people who've got impaired detox, which is most of my patients, that's where glutathione can be really helpful. I've got some patients who um, do intramuscular glutathione or intravenous glutathione if their gut isn't working well. You can also go upstream to N-acetylcysteine to produce more glutathione. That's a less expensive version for people who can't afford IM or IV glutathione. You want to think about the cruciferous vegetables. Are they eating enough of them? And also saunas. So here's a case to bring it all together. This is a 38-year-old woman. She's got a past medical history of endometriosis and fibrocystic breasts. She is COMT MET. You might have heard of COMT as the corporate warrior gene. So people who've got COMT MET, that's considered the joke is it's the Woody Allen gene. It's the warrior gene instead of the warrior gene. So as you may be able to tell, I am Val. I have the corporate warrior gene. Although as you get older, I think that becomes less relevant. But this patient is MET, and she's got the MTHFR 677 TT homozygous SNP. So her vibrant test showed high for hydroxy metabolites, low methylation, low 216 ratio. So what do we do for her? So going back to that previous slide, we give her DIM, we give her methyl donors, liver support, and some gut rehab. And the outcome is the symptoms improved, her estrogen profile normalized in 6 months. And you might say, well, 6 months is kind of long. But what we know with hormones, when you look at estrogen and you look at the estrogen metabolites, is that you want at least 6 weeks to see any sort of new steady state. Most of my patients, I don't retest until they've had some intervention like DIM and methyl donors and liver support and gut rehab for about 12 weeks. So 6 weeks is the earliest, 12 weeks is kind of the average. And then you might do some tweaking so that you get an optimal outcome by 6 months. So I think that's the best way to be approaching treatment. So, one of the key points here is that you don't want to wait until someone has breast cancer or endometrial cancer to start thinking about testing estrogen metabolism and methylation. We want to understand that estrogen detoxification is not optional. It's not a luxury. It is predictive. There's strong data behind it. And we want to be measuring methylation as well as potentially genomics, put it together with lifestyle so that we can optimize the health of these patients. There's a lot of different ways you can look at estrogen metabolism. I tend to use the Vibrant Hormone Zoomer. I think it allows you to deeply phenotype risk. And then you may also want to add on genomics, like I do, to see disease before it starts, to understand the blueprint for a patient so that you can then predict what are they at greatest risk for and how can we optimize for it? How can we use lifestyle to work around it? So I'm going to pause here. I think, Adair, we were planning to maybe take 2 questions if we have them.
Yeah, perfect. So the question that's come up the most since we started is what specific genomic test do you recommend for looking at those SNPs?
Yeah, great question. So I'm guided first by looking at metabolism. I like to kind of make a prediction about what I'm going to find with genomic testing. So the tests that I tend to run, and I can mention some of the labs because this isn't for CME. I tend to run the 3x4 test. So that gives me a whole hormone pathway. It gives me detoxification pathways, gives me the methylation pathway, including all of those SNPs that I mentioned earlier. So 3x4 is what I tend to use, and I pair that together with looking at metabolites.
Perfect. Big foes for 3x4, 3x4.
Yeah, let me mention one other. I like, Adair, you'll learn this about me. I like to not mention just one lab. I like to
Okay.
have a couple of options. So the other genomic test that I'm running a lot right now is IntellxDNA. So IntellxDNA is the 3x4 is looking at about 160 SNPs. IntellxDNA goes a lot deeper. So it looks at like 500 to 1,000 different SNPs, all of which are clinically relevant. And I tend to use IntellxDNA for someone who's got like an ApoE4 or a greater risk of Alzheimer's disease, and I want to go deeper. 3x4 is a lot less expensive. And so I often start there because it'll give you everything you need in terms of these SNPs related to methylation and estrogen metabolism.
Great. Thank you for that. Let's see. What was the other main question? We had a lot of questions about just monitoring HRT. Let me see if I can find that question from JD. So I know many who feel they can't monitor HRT effectively without urine testing alone should be used to monitor estrogen metabolites, but serum should also be used to monitor should we also use serum?
Yeah. Yeah, that's a great question. Wouldn't it be nice if we could just do one test and look at the whole picture? Unfortunately, that's not the case. So what I have seen over the course of my career, I'll try to give you the clinical pearl here, is that a lot of the outcomes are based on serum testing.
Mm-hmm.
I do a lot of serum testing because I work at an academic medical center, and it's the universal language of physicians and nurse practitioners and PAs. So I do a lot of serum testing, but for me, that's just a snapshot. It doesn't go deep enough. It's not comprehensive enough. So that's why I think urine testing, sometimes saliva testing, especially for cortisol, can be so helpful. So when this isn't the topic. I think there's another talk in the boot camp about all the different types of testing. But I would say serum is where I start. It's a quick snapshot.
Mm-hmm.
Urine testing gives me estrogen metabolites and also methylation. So I need it for comprehensiveness. And then I use saliva for cortisol. So that's kind of the way I think of it, a simplified way of thinking of it. Now, I can also tell you, when I first started teaching at A4M, they did everything in the saliva. I don't think that's good enough. I think you need all three. So my answer is all of the above.
Awesome. Thanks for that.
Sure. Okay, so we're going to keep going. As usual, we've got way more slides than we have time for, but that's how I like to roll. So I've got, let's see, I don't know how to get rid of JD's question. Maybe you know how to do that, Adair. Here's a simplified sex steroid synthesis. This is from my first book, The Hormone Cure, where I talk a lot about how to modulate these different pathways, and I try to make the complexity of estrogen metabolism a lot simpler. So you can reference my book if you'd like for additional help with that. So another key clinical pearl that I want you to know about is a concept that I learned, 20 years ago, 15 years ago from the Institute for Functional Medicine, and that is the PTSD framework. So this also speaks to JD's question and those of you that were asking about hormone testing. We want to think about levels. So that mostly is looking at production of hormones. So we want to measure serum estradiol on day 3 in someone who's cycling. I like to look at serum estradiol and FSH level. I want the estradiol to be between 20 and 80. I want the FSH in someone who's still trying to get pregnant to be less than 10, although you can still get pregnant with an FSH up to 15. So that's an example of production. But you want to be thinking of the entire ecosystem for hormone balance. And that includes not just production, but also transportation. So uh, for instance, your free testosterone level, you want to also look at sex hormone binding globule. What's going on with some of these carrier proteins that can act like a sponge? So, for instance, if you've got a patient who comes to you who's seen a conventional physician, maybe she's like the one I saw this morning, 49 years young, and she's on a birth control pill. The birth control pill raises sex hormone binding globulin that then robs you potentially of free testosterone, and that can modulate your metabolites. So you want to be thinking about not just production, but also transportation. Then you want to be thinking of sensitivity. So, we think a lot about insulin sensitivity, insulin resistance, but you can also have estrogen resistance. So I remember first reading in Luann Brisendine's book, The Female Brain, about how the female brain becomes resistant to estrogen around age 43. And that leads to brain fog and um, maybe some early subjective cognitive decline, less processing speed. So you want to be thinking about sensitivity with your patients too. And then detoxification. We've been talking a lot about detoxification. I just wanted to put it all together for you so that you're thinking about this framework. The mnemonic is unfortunate, PTSD, but it stands for production, transport, sensitivity, and detoxification. There's a lot of sex differences in the sex hormone life cycle that I think are important to mention. I just want to highlight that in women, there's this very steep slope in the decline of estrogen levels that begins typically sometime between 35 and 40, whereas men have a much more gradual decline in testosterone, as indicated here. There's more than 100 plus symptoms associated with perimenopause and menopause, and they have a timeline that's indicated here. And so, once again, you kind of reach right around age 43, kind of this peak estrogen level. And then there's this gradual decline. It can fluctuate wildly. And that's what tends to trigger all the symptoms. I'm going to skip this slide for the sake of time, as well as this one. And let's talk about the matrix. So, for those of you that do functional medicine, you probably think in terms of matrix. I have to have permission from IFM to use their functional matrix, but I don't need permission from Andrea Nakayama, who uses this one, the functional nutrition matrix. But the point I want to make is that even the concept of PTSD, we want to be thinking about all the different systems. We want to be thinking of ATMs. If you've done any functional medicine, you know about the antecedents, the triggering events. I was well until this happened, and also the mediators. Those are the ATMs. We also think about lifestyle factors like sleep, which can affect so many hormones like cortisol and insulin. We want to think about exercise, all these different lifestyle factors, stress and resilience. And then in the middle of the matrix, when it comes to things like estrogen and estrogen metabolites, we want to be thinking of all of these. So, not just hormone production, but detoxification, oxidative stress, environmental inputs, like how many xenoestrogens or endocrine disruptors a person is exposed to. We want to be thinking of inflammatory balance in the immune system because estrogen is a really important immune modulator. So is progesterone and testosterone and DHEA, vitamin D. Gastrointestinal effects. We talked about that related to the hypothalamic pituitary adrenal, thyroid gonadal, gut, genomic axis, and then structural integrity. I was talking to this patient this morning who's got frozen shoulder at age 49. And I think that's related to her estradiol levels. We know that the musculoskeletal syndrome of menopause can affect women in their 40s. So we want to be thinking more broadly about this whole ecosystem. And then you've got in your slide deck the role of estrogen, this a matrix that I made just to kind of show the different factors related to estrogen. And we want to be thinking, of course, about metabolism and methylation. So you've got that in your slide deck. So one of the things I do in my patients is I like to measure pregnenolone, serum pregnenolone. And for some people, it starts to decline in their 30s. For other people, it never declines. It's worth measuring. And again, I like to see a level of about 100. So you've got some details on pregnenolone. You also have some additional details on hormone assessment to answer some of your questions about patients who are on hormone therapy. You're, of course, familiar with all the different routes that we have, and that then maps to different optimal ways of measuring some of these levels. There's different body compartments. Again, this was in a different talk that you got, so I'm going to pass through these. You've got some information on testosterone. I'm going to go to the clinical takeaways, and then we'll take some additional questions that you have. So the main point I want you to remember when it comes to methylation and also with estrogen metabolism is that we've got this bigger control system for regulating key hormones, including estrogen. The hypothalamus, pituitary, adrenal, thyroid, gonadal, gut, genome axis. So we want to be thinking about all those different parts, the control system, and what's going on in the patient that we're taking care of. When it comes to measuring sex hormones, I like to look at pregnenolone in the serum. I like to look at cortisol in saliva as well as dried urine. I typically start with the serum level. I like to look at estradiol. Serum is the gold standard. That's where I start. I look at sex hormone binding globulin, but I tend to use urine testing in women who are perimenopausal and menopausal because urine testing, like you get with the Hormone Zoomer, augments what you get with serum testing. It gives you a more comprehensive picture. So with testosterone, serum again is the gold standard. Add sex hormone binding globulin, but then I also like to look at urine testing because it's comprehensive and it gives me metabolites. And same story with progesterone. So I'll finish with this particular slide that we want to be thinking of this broader ecosystem for creating hormonal harmony, whether that's a woman with PCOS who's in her 20s or 30s, or it's a woman in perimenopause, or a woman in her 60s with menopause. So we want to be thinking of the sex hormones, of course, as well as the metabolites. We want to be thinking about lifestyle and how that maps to hormonal balance, endocrine disrupting chemicals, the control system, inflammatory tone, the role of mast cells and macrophages, other endocrine glands, including the thyroid and the pancreas. The thyroid can affect estrogen levels and vice versa. We want to be thinking of the gut microbiome. So with that, I think we're ready for our questions, and we've got some time for that.
Perfect. Thank you for that presentation, Dr. Thal. All right. So going back to the beginning, Maria wants to know what's the best way to lower 4-hydroxy naturally with supplementation.
Yeah, so we had a slide on that.
Okay.
The thing about 4-hydroxy, okay, so let's do the clinical pearls first. What I found is that 4-hydroxy is harder to modulate compared to 2-hydroxy and 16.
Okay.
Seems like you found that also, Adair. So, you know, I wish that all of these, I wish it were a democracy, but it is not. So the 4-hydroxy pathway is harder to modulate. And what I found with my patients, I don't know if I can go back to my slides here.
Oh, sure.
The 4-hydroxy, I think, was kind of early on. Just I know which slide it is.
And then we also had a follow-up question related to that, which is, what would you recommend for someone postmenopausal who has low estrogen but favors this?
Yeah, this is a good question. So, okay, so we've got the slides. Let me see if I can go back to the 4-hydroxy page. Can't remember exactly. It seemed like it was like a third in.
Yeah, I'm looking for it on my end too.
Yeah, here we go. So these are the interventions that make a difference. So DIM or indole 3-carbinol green tea extract. So I find that those have some benefit, but you know, often I would say we're at the learning to crawl stage with figuring out
Mhm.
how to personalize what works best. So I have some patients who do green tea extract and it really works for them. And I have others where it doesn't work very well. And we end up having to do like a detoxification every quarter or once every 6 months where they really focus on glutathione detoxification.
Mm.
This is also a patient where I do genomic testing to see what else we can do to modulate the 4-hydroxy pathway. So that's what I would say in terms of treatment.
Got it.
And
That's
same thing, in terms of this other question about what do you recommend for someone who's postmenopausal, who has low estrogen but favors 4-hydroxy? Yeah, I wouldn't give DIM to someone who is postmenopausal unless they're on hormone therapy. If they're on hormone therapy, I'll give DIM or I3C and then focus on what else we can do to modulate it.
wonderful. Thanks for that. Do you have time for one more or do you have to run?
Yeah, let's do one more. I've got my patient's right at the bottom of the hour.
So relatedly, what do you suggest for patients with that COMT variant who do not tolerate the methylated B12 or the SNP?
Yeah, so these patients, I really focus on getting the methylators from their diet.
Mm.
So nobody's going to make money off of this, but I find for these are often really highly sensitive patients like HSPs. And what I often find is that if you really focus on the methylators and increase how much they're getting from their diet, and I think Kara Fitzgerald has done the best work here. So, she does, I think I can mention brands. She did her study initially in a group of men looking at methylation clocks and showed that in a 8-week program, I believe, she could reverse biological age. And a big focus of her work is giving people methylators. So that includes beets, lots of other foods that are rich in methyl donors. And so I'd refer you to her work in this situation. She also used a metagenics like greens product. I think a lot of different greens products can help you with getting those methyl donors.
Great. So people who can't tolerate supplementation, get it from your diet. Really push those methyl-rich foods. Love it.
Yeah, I mean, the same is true for iodine. I think a lot of people can't tolerate iodine very well in a supplement form. So I would say go back to the basics and focus on lifestyle and how much you can pull that lever.
Perfect. Thank you. Thank you so much for sticking around for all the questions that we had time for today. Thanks so much, everyone. Have a great rest of your day. Take care.
Bye, everyone.
This webinar is for educational and informational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by guests and hosts are their own and do not necessarily reflect the official policy of Vibrant Wellness. As always, consult your healthcare provider before applying any recommendations that you have heard here today.